Good afternoon, everyone. Pleasure to be here. First time in a football stadium. For those that don't know me, my name is Alia Gilani. I'm a diabetes specialist pharmacist. And I think the hardest thing about today's presentation, apart from standing in front of you all, is encapsulating the last 20 years in 15 minutes, but I'll try my best. So I've titled this presentation, Managing Diabetes in a Diverse Community. So our agenda today, I'm going to split it into three parts. I'm going to set the scene, talk about background, why is it important as healthcare professionals that we think about working in a diverse community? Why do we need to think about our service and tailor that accordingly? Then I'm going to depict a case, one of my favourite cases, back in Scotland. For those that can't tell, I'm Scottish. I've been here for the last 3.5 years. And then I'm going to show some photos. The last section, I'm going to sum up with some lovely photos of some work I've done in Scotland and more laterally down in Sheffield. So we've got a lot to cover in the next 15 minutes. Okay. So what are health inequalities? Health inequalities are simply the difference in the health status or the distribution of health determinants between different groups. That's by the World Health Organization. And why is that important? By 2051, the whole of England and Wales will be as diverse as London is now. So we have to think about our service. One shoe doesn't fit all. So ethnic inequalities were first depicted by a German philosopher in 1800, Friedrich Engels, 1845, and he actually noticed that Irish immigrants were dying quicker than the sort of English white European populations. That's when it was first identified. What causes ethnic inequality? So my passion's been health inequalities, particularly ethnic inequalities, for the last 20 years. So let's look at factors, and we've not got time to go into this, but this has been written by an Edinburgh epidemiologist, Raj Gopal, really interesting paper on the factors that contribute to ethnic inequality. So there's lots of factors he's described, but what's interesting is genetic factors. We think that plays a big role, but there's actually more genetic variation within a group than there is between a group. But these play a small factor. Socioeconomic is probably one of the biggest drivers, so you have more deprivation in those from ethnic minority backgrounds. And there's a factor in there that's not mentioned, but that's a different journal or different studies. It is racism, but that's quite difficult to encapsulate, and it's also a very sensitive factor. So it's multifactorial, the contribution to ethnic inequalities. So the relationship between culture and health, it impacts in every aspect. For those of us that are managing diabetes, it is important. It encapsulates every facet of their life in terms of how they perceive the disease, how they live their lifestyle, their family, medication, attendance to appointments. In the South Asian community where I've worked with, the concept of fatalism, that you leave everything to the hands of God, so you don't have to do anything, so almost that negates responsibility, but I've got a great answer for that. As healthcare professionals, we need to think about cultural competency versus sensitivity. What is the difference? So being culturally sensitive is simply being aware of the differences between different cultures. Being culturally competent is actually taking action, so you're being more proactive. So we have to think about our services in terms of delivering it in a culturally competent way. And I like this description because sometimes when I've written for journals on working in diverse communities, I sometimes get I get the journal articles reviewed and they said, but we don't work with several. It's impossible for us to know about every ethnicity. You're absolutely right, but cross-cultural kind of understanding or communication and respect and sensitivity is less about your knowledge, but it's more an attitude, and I quite like that. I've worked in one of the largest asylum seeker practices in Scotland, 90 languages. I've done consultations where the interpreter's not turned up, so it's more about your attitude. I like that description. I wanted to describe, it's really hard to describe in the sort of 20 years, a really good case study, but I like this one. It's one that always stands out. So this gentleman was early 30s. He was initially, he was diagnosed December 2018. He had fatty liver, pre-diabetes, and he went for a consultation and they explained this all to him, but he pretended to understand what they were saying in English. His understanding of English was very minimal. So they thought, the healthcare professional thought he understood. He pretended he understood. So he went off his merry way, and 6 months later developed diabetes. His control wasn't that bad. It was HbA1c, he was in sort of mid-50s, got started in metformin, referred to my service. I was working in a practice, so when I did the consultation with him, so I do the consultation in Urdu, I'm able to speak Urdu, and his gentleman, he'd just moved from Pakistan, and this was what was key, the social history. He'd moved and he was working really long hours in a warehouse, and he said he was really upset that he'd got diagnosed with diabetes. How did this happen? I had no idea, and I've got, what's happened to my liver, and I told him it's reversible. It's simply by losing weight, and he said he'd no hours in the day. He couldn't speak English, and he's working these long hours. He's got a child at home. So the solution was, it just happened to come to me that I pointed to a bicycle helmet that I had on the desk next to me, and I said, "Oh, do you know, you're right about time. None of us have got time, but I cycled into work, so maybe that's something you can consider, and cycle along to the warehouse." And there's also this concept of diabetes being associated with your consumption of sweet food. All the Asian aunties and uncles, that's the first thing we'd say, but I don't eat anything sweet. Versus in the not giving them the knowledge that it's carbohydrates. So anyway, he ended up getting a bike. We did a family-based review, and that's really important with those that are high risk, particularly the youngsters, the ones that are difficult to engage with. And the ones that we can't engage with are often the ones that we should never give up on, because we know that inverse care law holds true. Those are the ones at highest risk of morbidity and mortality. So if the wife is the one that's in charge of the food, it made sense to have her in the consultation. So we talked about the concept of carbohydrate. We set them practical, manageable goals, like cycling to work, kind of understanding the impact of carbohydrates and not omitting them, because I think in a literal sense, in some communities, if they don't eat particular foods, like rice and in the Asian community, chapatis, they would look at me and say, there's literally nothing else to eat. That's what they think. So we have to be realistic and not omit them completely from the diet, but we can set them, manageable goals like halving your carbs and increasing protein and vegetables. So he got the bike, used to cycle to work, had more protein-based food, reduced his carbs, and lost 10 kilos, and then went into remission. So he was really delighted to get his photo taken in the tea room. So he lost 10 kilos, went into remission, loved cycling so much that, bless, he wanted his wife, pictured he was his daughter, to start cycling as well. And poor thing, so he lived in quite a rough part of Glasgow. He got his bike stolen twice, but he still persevered. So that was an example of a case. So I want to kind of finish off with the last section in the last 5 minutes of other examples of how you can engage and work in a diverse community. So currently I work for Seven Hills Network in Darnall, primary care, and special mention to my lead, Alistair Burgess, who's really supported the work that I'm doing in the last 3 years. So this is examples of what I've done in Scotland. So my view, access is an issue. So we've taken services out to the community. This is the largest mosque in Scotland, running an elderly centre, male and female elderly patients in different days. It was difficult, believe it or not, for me to get in there, but it was fortuitous that the GP that was the secretary of the mosque happened to be the place that I did the pilot, so he managed to kind of get me in and tell me that she's not bad. So we did the service there. Out in the community, 90 attendees as in a community centre, local consultant, dietitian. They did a duet talking about the risks of diabetes with lots of representation from Retinal Screen, Diabetes UK, so we're managing to get 90 people. And a few days prior to the event, we had all the aunties asking me when the party was, because they wanted to dress up. I thought it was a party and event, a very interactive event. This is my practice, my old practice before I moved down to Sheffield. Simply close the door, 6 o'clock when it closes, we use the waiting room. And you can see there's a male personal trainer and South Asian sort of aunties. I did say to them it was a male trainer, and they said absolutely fine. Changed people's lives. We had one lady who, from that day, started walking every single day. on insulin, had schizophrenia, and I know she wasn't lying because I used to bump into her for the next 4 years working in that practice. So these sessions are really powerful. Jason Gill, some of you, Professor Gill, might know from BBC programme. He's done amazing work on exercise and metabolism at Glasgow Uni. So he worked with me in one of the charity groups that I was leading in Scotland. And he managed to hold the attention of 30, 16-year-olds in my old secondary school. Because why aren't we starting at the beginning, talking about prevention? We've got more and more youngsters, people in their 20s and 30s who've got diabetes and complications. So being out to the school, this is another thing that we need to think about, is using the community leaders to disseminate that information and getting it to trickle down. So this was one of the sheikhs, the imams, and he did a session with me where I talked about the clinical aspect of managing diabetes in Ramadan, and he did the Islamic perspective. And he actually, that session, there were 70 attendees from NHS. It led to the change of the Scottish Ambulance Service guidelines. So these things are really powerful. I wanted to put this up. This is something I do with some of my patients. I get them to do food diaries, and you can really see, because you can give them simple messages, but you're not with them all the time. And you can see for this gentleman, he was on insulin. You can see why that he had high blood sugars. He's having like Frosties and cornflakes every day, bar Saturday crisps as a snack. So, and the ones that fill it out tell the truth, because you can see the high carbs, like 4 slices of bread and pita bread. So we can see where he kind of went wrong. The other thing, model, that I'm a big advocate for is joint clinics. We can't manage a complex disease like diabetes on our own. We have to work closely with a multidisciplinary team. I'm a big fan of joint clinics. I've done it with social work, with the DSNs, and this is a service I did regularly in Glasgow, working with the local DSN, Leanne. She was unable to get access to South Asian individuals to the service. I used to get them through the door. She was the expert in insulin. I was able to prescribe, and the service worked beautifully. We ran it once a month. By the end of it, she was able to understand Urdu, even though she couldn't speak it. And he was obviously delighted to get his photo taken. This is in Darnall, so this is more laterally. The work I'm doing in Darnall is community education. This session actually was 3 different languages, well 4 if you think about Scottish. So I had to say a sentence and then wait for each interpreter to translate. So that was rather challenging for me. So we've done it in topics like diabetes, medicines, Ramadan. Tinsley, been working out in Tinsley Community Centre, and what we've done recently is set challenges. So each person that attends sets one thing that they'll change in their behaviour, and then we revisit in a couple of months, and we show them like things like fruit and portion size. Tips for engaging. So if you've got a hard-to-reach patient, use a family member, as long as you get consent. I think they can be your ally often. I've even had to use the local newsagent when it's been hard to reach patients. Follow-up prompts, there's evidence that changes behaviour. That could be a text, that could be a quick phone call. That's really useful. Use your community leaders, ask the mosque when it's Ramadan to come in, go out to the mosque when it's Friday prayer and there's a big gathering. We need to use more easily accessible venues if we can. Clinics don't have to be in a practice. I'm a big believer. Using culturally sensitive resources, which I'll show you, that's some that I've developed, but they're really hard, I get, to access. We need to be cognizant of the wider determinants of health. If we look at the Dahlgreen-Whitehead model of health, the social and healthcare impact has a greater impact on patients' lifestyle. Whilst we don't have necessarily time, we can be used as a gateway to refer patients into the health and social care team. And just to finish off, I have it's really hard to get culturally sensitive or appropriate resources, so we developed our own in Darnall. Anyone wants one, I've got my email address at the end. They're little booklets, 10 top tips of practical management, and at the last page we've got useful resources. I've developed it with Rebecca Gilpin, one of the practice nurses, and I've also developed one for Ramadan, which is a month of the year, and it has a great impact on those with diabetes, so I'm happy to share them. Thank you so much.